Imagine stepping onto an emergency ward for, like, the absolute first time.
Oh, it is terrifying.
Right. The fluorescent lights are blinding, telemetry alarms are just screaming from every direction, and, well, a senior nurse hands you a clipboard filled with what basically looks like an alien language.
And you don't have the luxury of opening a dictionary or Googling a phrase?
Exactly. Because if you misunderstand a single word in this environment, I mean, a 73-year-old man might die.
The margin for error is essentially zero. When you enter a clinical setting, you are suddenly immersed in this highly specialized, incredibly dense dialect.
Yeah.
And you're expected to process it at the speed of a crisis.
Which is wild.
Okay.
And that terrifying high-stakes scenario is the mission of our deep dive today.
Okay.
We are stepping into the shoes of a brand new nursing student navigating the chaos of the Moonlight Bunny Clinic.
Such a great case study to look at.
It really is. We've got our hands on a clinical handover script and a detailed medical glossary from the clinic. So our goal is to, decode this intense medical jargon.
Break it all down.
Right? Uncover the actual mechanical and chemical rationale behind these procedures and learn how healthcare professionals bridge that gap between clinical precision and human empathy.
It's really a process of translation. We're going to take this intimidating wall of clinical terms and deconstruct it until the human being behind the jargon becomes, well, completely visible to you.
So to put you directly in the mindset of that nervous new student, I'm going to attempt a dramatic reading of this handover.
Oh, let's hear it.
Wish me luck. This is Nurse Turtle, a junior nurse calling the Coronary Care Unit about a patient named Mr. Cat. Deep breath. Here we go.
Take your time.
Okay. Hello, this is Nurse Turtle from the emergency department. I'm calling to provide a handover for Mr. Cat, a 73-year-old patient, MRN 012345.
Good start.
He's being transferred to your coronary care unit for management of acute congestive cardiac failure.
Right, the CCF.
Mr. Cat was brought in by ambulance at 07.0 this morning with severe dyspnea. He's becoming increasingly lethargic and tired. He feels like he is drowning and is currently in an isolation bed for assessment. He has a history of CCF, hypertension, and COPD, likely linked to his 25-year history of smoking 30 cigarettes a day.
That's a massive detail.
Yeah, I know. He woke up breathless at 21 Zerlilo last night. Importantly, he has a shellfish allergy.
Gotta catch that.
His current medications include salbutamol, Symbicort, and 2.5 milligrams of Rememprol. My A to G assessment is as follows.
Here comes the dense part.
Seriously. Exhibiting pursed lip breathing, he is tachypneic at 36 breaths per minute and diaphoretic. He has a PIVC in his left arm.
Okay.
The medical officer has ordered the CCF pathway. We have already administered 40 milligram Furosemide the fifth, 2.5 milligram morphine the fourth, and applied a 50 milligram GTN patch.
Wow.
Almost done. Please continue continuous cardiac monitoring and aim for SExBO2 above 92 to 95% using nasal prongs. We need to keep him in the semi-Fowler's position. He is ready for transfer now. Do you have any questions for me?
Phew, I mean, that breathless, slightly overwhelmed feeling you get just reading that out loud, that is completely intentional. It really illustrates the massive cognitive wall a beginner faces.
Oh, absolutely. I felt like I was running a sprint.
Right. You are trying to process terms like tachypneic and diaphoretic while simultaneously keeping track of drug dosages and patient history.
It feels less like a description of a 73-year-old man and more like an instruction manual for, a highly volatile piece of heavy machinery.
That is a very accurate comparison.
But why do nurses and doctors speak in this incredibly rigid, dense format? I mean, Nurse Turtle could just call the other ward and say, hey, I've got Mr. Cat, his heart is failing, he can't breathe, we gave him some meds, and we're setting him up.
Well, casual storytelling in medicine introduces a massive vulnerability.
How so?
When a patient is crashing, the human brain is flooded with stress hormones. Working memory shrinks dramatically.
Oh, right, tunnel vision.
Exactly. If a nurse just tells a narrative story, human nature dictates they will emphasize the parts they found most dramatic in the moment.
So they might talk about how panicked the guy was, but completely forget mundane but fatal details.
Yes. Like the shellfish allergy. Nurse Turtle is using a framework called ISBAR, which stands for Identification, Situation, Background Assessment, Recommendation.
Okay, so is this essentially like a pilot's pre-flight checklist?
Very much so.
Like a mandatory structure designed so that when your adrenaline is pumping and the alarm bells are ringing, you don't forget to deploy the landing gear.
A checklist removes the cognitive burden of trying to remember how to organize information. The nurse can focus entirely on what the information is.
Right.
Nurse Turtle starts with identification. This is Nurse Turtle. I have Mr. Cat, MRN 012345. That medical record number ensures they are looking at the exact same digital file.
Which prevents a catastrophic mix-up.
Precisely. Then situation, the acute problem right now. Background, the medical history. Assessment, what the physical signs are at this exact second.
And finally, recommendation, what needs to happen next.
Exactly. This structural scaffolding prevents fatal communication errors where one provider assumes the other provider already read the chart.
So the ISBAR framework provides the scaffolding,
Yeah.
but, the words filling that structure still feel completely alien.
They do, yeah.
If we're acting as a language guide for our nursing student listener, we need to bridge the gap between this clinical jargon and the everyday reality of what Mr. Cat is experiencing. Nurse Turtle says he was brought in with severe dyspnea.
Right, dyspnea. It's spelled Dyspnea. It is the clinical term for shortness of breath, but, that translation doesn't quite capture the horror of it.
Shortness of breath sounds so mild, like you just ran up a flight of stairs.
But in this context, dyspnea is the subjective, agonizing sensation of air hunger.
Air hunger. That is a terrifying phrase.
Imagine holding your breath underwater just a second too long, that primal desperation for oxygen. That's what he's feeling. Then Nurse Turtle identifies the root cause, acute congestive cardiac failure, or CCF.
Okay, so we hear heart failure, and we usually picture like a sudden heart attack where the heart just completely stops.
Mm-hmm.
But failure in this context just means the heart isn't working efficiently, right? Mm-hmm. And the congestive part implies some kind of traffic jam.
That's a great way to look at it. The heart is basically a mechanical pump moving fluid through a closed loop of pipes.
Okay.
If the pump weakens over time due to age or high blood pressure, the fluid doesn't just stop moving, it backs up.
So where does it go?
Well, in Mr. Cat's case, the left side of his heart, the side responsible for pumping freshly oxygenated blood out to the entire body, is failing. Because it can't push the blood forward effectively, the blood backs up into the system right behind it.
Which would be the lungs.
Exactly.
Wow, this connects directly to the most visceral line in the entire handover. Mr. Cat tells the nurse he feels like he is drowning.
Yes.
The clinic's glossary notes that his condition is literally pulmonary edema. The backed up fluid is being pushed into his alveoli, which are those tiny air sacs in his lungs.
The hydrostatic pressure inside those pulmonary blood vessels gets so high that it literally forces fluid through the vessel walls and into the empty air spaces.
Oh my God.
So when Mr. Cat tries to take a breath, the oxygen physically cannot cross through that layer of fluid to reach his bloodstream. He is actually drowning from the inside out.
Wait. If the patient perfectly describes their reality as drowning, and physically they actually are drowning in their own fluid, why do medical professionals translate it into a dry academic term like pulmonary edema?
It's a fair question.
Like, why strip away the human experience?
Well, the medical term diagnoses the mechanical location and cause of the problem. If you shout to a doctor that someone is drowning, the immediate clinical assumption is water aspiration.
Oh, like they fell in a pool or something.
Right, which dictates a totally different resuscitation protocol. Pulmonary edema tells the entire medical team exactly where the fluid is and why it's there.
Okay, that makes sense. It's for clarity in an emergency.
We use medical terms with colleagues for absolute precision, but effective nurses have to understand the lay terms too.
Right, you wouldn't say pulmonary edema to the patient.
No, telling him he has pulmonary edema might just confuse him, whereas acknowledging that his lungs feel full of fluid validates his terrifying experience.
That is such a crucial distinction. It's about knowing your audience. And Mr. Cat's audience is a medical team that needs to know his history, which includes COPD, chronic obstructive pulmonary disease.
Yeah, COPD is a chronic inflammatory lung disease that causes obstructed airflow. Those tiny air sacs we mentioned, the alveoli, they lose their elasticity.
Usually this is caused by long-term exposure to irritating gases, right? Which explains Nurse Turtle highlighting his 25-year history of smoking 30 cigarettes a day.
Exactly. His lungs were already severely compromised before his heart even started failing.
So we know what is happening mechanically inside his chest, but what does that look like to Nurse Turtle standing at the bedside?
The physical clues.
Yeah, the assessment portion of the handover outlines those red flags. She notes Mr. Cat is tachypneic at 36 breaths per minute. Tachy meaning fast, neic relating to breathing.
A normal resting respiratory rate for an adult is anywhere from 12 to 20 breaths per minute.
So 36 is huge.
Taking 36 full, desperate breaths in 60 seconds is exhausting. His body is starved for oxygen, so his brain is screaming at his lungs to work harder. He is essentially running a marathon while lying flat in a hospital bed.
That is terrifying. She also notes he is diaphoretic. He is sweating profusely, and the glossary specifies this often presents as cold and clammy skin, specifically with cool peripheries like freezing hands and feet.
All right. Now, sweating usually means you are hot, but in this context, it is a massive red flag for poor perfusion or even cardiogenic shock.
Shock.
Because his failing heart cannot maintain blood pressure, his body enters a severe fight or flight state. It dumps adrenaline into his system, triggering the sweat glands. That is the diaphoresis. Simultaneously, the body realizes it is in crisis mode and clamps down the blood vessels in the arms and legs to shunt whatever oxygenated blood is left toward the vital organs, the brain and the heart.
So the extremities get cold and clammy because the blood flow has essentially been redirected away from the skin.
Exactly.
Every single symptom is a screaming siren, if you understand the biology behind it. And then Nurse Turtle mentions a very specific physical action. Mr. Cat is exhibiting pursed lip breathing. He is forcing his exhales out through puckered lips.
This is a classic physiological response for patients with COPD. We know his alveoli have lost their stretch and elasticity.
Right.
When he exhales normally, the pressure inside his chest drops. Because his airways are damaged, that drop in pressure causes the tiny air passages to collapse completely, trapping stale, useless air inside his lungs.
Okay, wait. Is this kind of like putting your thumb over the end of a flowing garden hose?
Yeah.
You restrict the exit to build up the pressure inside the hose itself?
That is a perfect analogy. The restricted exit creates what we call back pressure. In clinical terms, this is positive and expiratory pressure, or PEEP.
PEEP, got it.
By pursing his lips, Mr. Cat is using his own mouth as a valve. The back pressure acts like an invisible pneumatic splint, holding those damaged airways open just long enough for him to force the trapped stale air out so you can take a fresh breath in.
It is remarkable that the human body instinctively utilizes fluid dynamics to keep itself alive.
It really is.
But, I mean, instincts and puckered lips aren't going to fix a plumbing disaster of this scale. We have a failing pump, fluid in the lungs, and collapsing airways. Physical interventions aren't enough. We need chemical intervention.
Absolutely. And that's where Nurse Turtle relies on a PIVC, a peripheral intravenous cannula.
The IV line.
Right. It is the standard IV line in the arm, acting as a superhighway to deliver heavy-hitting medications directly into the bloodstream without waiting for digestion. The pharmacology here addresses two distinct crises, fluid management and airway management.
Let's look at the fluid management first. Nurse Turtle administered 40 milligrams of furosemide the fief. The glossary identifies this as a loop diuretic, commonly known by the brand name Lasix.
A loop diuretic targets a specific structure in the kidneys called the loop of Henle.
Okay.
Mr. Cat's failing pump has caused fluid to back up, so we need to drain the system. Furosemide forces the kidneys to aggressively filter sodium and water out of the blood and excrete it as urine.
So we are unloading the excess volume, physically draining the fluid out of his lungs to take the pressure off his heart.
Exactly.
And for any nursing students listening, especially those in Australia or using older textbooks, the clinic's glossary notes you might see this drug spelled Furosemide.
Yes, that's an important note.
The global medical community has standardized the spelling to furosemide to prevent prescription errors, but it is the exact same medication.
Consistency in drug nomenclature is a massive part of patient safety. Now, alongside the furosemide, Nurse Turtle applied a 50 milligram GTN patch glycerol trinitrate and noted he takes 2.5 milligrams of ramipril. Ramipril is an ACE inhibitor, and GTN is a nitrate.
Both of those cause vasodilation, right? They widen the blood vessels.
Returning to our plumbing analogy, if you have a weak, struggling pump, forcing it to push fluid through narrow, highly pressurized pipes will eventually cause the pump to burn out entirely.
Makes sense.
Vasodilators relax the smooth muscle in the walls of the blood vessels, making the pipes wider. This drops the blood pressure and dramatically reduces the workload on the heart, allowing that weak pump to move blood more effectively.
Brilliant. Then we tackle the airway management. He is on salbutamol and Symbicort. The glossary clarifies that salbutamol is a short-acting beta-2 agonist.
Yes.
It is a rescue medication that rapidly relaxes the muscles around the airways to open them up. Symbicort, on the other hand, is a long-acting combination of a bronchodilator and a corticosteroid used for daily maintenance.
Think of it this way. Salbutamol is the emergency crew dispatched to clear a fallen tree off the highway right now. Symbicort is the maintenance crew filling potholes and repaving the road every day to prevent future accidents.
That makes it so much clearer. But hold on, there's a medication on this list that seems incredibly dangerous given the circumstances.
Oh, I think I know which one you mean.
Nurse Turtle says she gave Mr. Cat 2.5 milligrams of morphine the 5. Morphine is a heavy narcotic. We all know that a primary side effect of narcotics is respiratory depression. They slow down your breathing.
They absolutely do.
So why on earth would you give a drug that suppresses breathing to a man who is turning blue and fighting for every ounce of oxygen? That sounds like a lethal error.
It seems entirely counterintuitive, I completely agree. But in acute cardiogenic pulmonary edema, morphine is a brilliant dual-purpose tool. Consider the sheer psychological terror of suffocating. That panic triggers a massive release of adrenaline, which forces the heart to beat faster and pushes blood pressure even higher.
Which completely overwhelms the already failing heart.
Exactly. Morphine blunts that crippling sympathetic nervous system response, breaking the panic cycle.
So it stops the brain from sabotaging the heart.
Precisely. Plus, it actually works as a mild vasodilator, too. It relaxes the blood vessels slightly, pooling blood in the venous system, which decreases the volume of blood returning to the heart at any given moment.
Oh, wow.
It offloads the struggling pump. Now, the clinical team monitors his respiratory rate constantly because of the depression risk, of course.
Right, you have to watch them like a hawk.
But in a highly controlled emergency setting, calming the nervous system and easing the heart's workload is a calculated, life-saving necessity.
That nuance changes how you view pharmacology entirely. So with these medications aggressively manipulating his internal plumbing and chemistry, the final piece of the handover involves his physical environment and ongoing care. Nurse Turtle is transferring him to the CCU, the Coronary Care Unit.
Yes. The Coronary Care Unit provides a completely different ratio of care. Instead of a nurse managing 5 or 6 patients on a general ward, a CCU nurse might only have 1 or 2.
And the primary tool in this environment is continuous cardiac monitoring, or telemetry. They place electrodes across his chest to watch the electrical rhythm of his heart on an ECG monitor in real time.
And that's crucial because a heart failing under immense pressure physically stretches.
Okay.
That stretching can disrupt the electrical pathways that tell the heart muscle when to contract. The heart can easily slip into chaotic, irregular rhythms like atrial fibrillation or AFib.
Where the upper chambers just quiver uselessly instead of actually pumping.
Exactly. The telemetry monitor alerts the team the microsecond one of those electrical misfires occurs.
Nurse Turtle also notes they're maintaining his oxygen saturation, his SpO2, above 92 to 95% using nasal prongs. And she mentions that the medical officer has ordered the CCF pathway.
The CCF pathway is a standardized, evidence-based protocol utilized across hospital systems. It guarantees that regardless of which doctor happens to be on call at 2 in the morning, Mr. Cat will receive the exact same sequence of best practice care.
It removes the guesswork from an escalating emergency. You know, out of all the high-tech interventions we have covered, the telemetry, the intravenous loop diuretics, the carefully calculated vasodilators, the instruction that stands out to me the most is the final one Nurse Turtle gives.
Which one?
We need to keep him in the semi-Fowler's position.
Yes. That simply means keeping the head of the hospital bed raised to an angle of 30 to 45 degrees.
I just marvel at the elegance of that intervention. After navigating the complex chemistry of ACE inhibitors and the physics of PEEP, sometimes the most profound medical intervention is just sitting the patient up.
It really is.
You let simple gravity pull the abdominal organs downward, pulling the diaphragm down with them, giving those fluid-filled, drowning lungs just a fraction more physical room to expand inside the chest cavity.
It perfectly illustrates that medicine is not just biology and chemistry. It is mechanical engineering, it is physics, and it is compassionate physical care.
We started this deep dive with a handover script that looked like an impenetrable wall of terrifying jargon. By breaking it down, we can clearly see the mechanical, chemical, and physical steps required to pull a human being back from the edge.
It really is an incredible process.
We see the scaffolding of the ISBAR framework actively preventing cognitive overload and errors. We see the loop diuretics and vasodilators manipulating fluid dynamics to save a failing pump. We see the human body desperately utilizing back pressure through pursed lips to keep its own airways from collapsing.
Underneath all that intimidating, specialized terminology, there is a very logical, systematic approach to solving the crisis. The alien language is just a tool for rapid problem solving.
It changes how you listen to the language of medicine entirely. But it also leaves me with a final lingering thought for you to mull over as we wrap up today.
Let's hear it.
The term congestive cardiac failure sounds incredibly definitive. It is mechanical, objective, and almost safe in its detachment. But to Mr. Cat, lying in that hospital bed, it is not an objective mechanical failure. It is the visceral, subjective terror of drowning from the inside out.
Right.
As we train the next generation of healthcare professionals to master these rigid, life-saving clinical pathways and specialized dialects, how might healthcare and ultimate patient outcomes change if medical charts were designed to equally prioritize the patient's own vivid, terrifying metaphors alongside the clinical terminology?
What happens when the subjective human experience is treated as just as vital as the objective data?
Exactly. Integrating the human narrative with the clinical data could fundamentally alter the empathy and effectiveness of future care.
That is a powerful question.
Something to think about the next time you find yourself navigating a complex, unfamiliar system. We'll leave you with that. Keep questioning and keep learning.